Hello and welcome to Guy and John. It's Greg Allen here, the Chief Executive of Future Care Capital. This is another one of our Future Care chats where I talk and chat with leaders from across the health and care sector and beyond. And I'm really delighted to have you with me today, Guy and John. I'll cross over to you in a second, but I just wanted to say a little bit about Future Care Capital and why we're here. My organisation, Future Care Capital, is a 70-year-old national health and care charity, and our core focus is on helping to shape the future of health and care policy. So we bring together policymakers and practitioners to shape the conversation. And I suppose our approach is all about informing and connecting people and transforming as well through a lens of data, technology, innovation, and how you scale that. So I'm very interested in having this chat with you because obviously in your roles running academic health science networks, innovation I know is a big part of what you do. And I'm sure we'll talk about that in the context of the last 6 months and the challenges we've been having. But I'm really keen to look at the future as well, the future of health and care, the future of work and well-being around that. So Guy, if I go over to you first to introduce yourself.
Yeah, thank you, Greg. I'm very impressed with you presiding over a 70-year-old organisation. So Kent Surrey Sussex Academic Health Science Network is one of 15, and we've been around for about 7 years, I suppose, with a remit to strengthen collaboration between industry, academia, and the NHS, or I think, as John and I like to call it, the independent sector, academia, with NHS and local authorities or health and social care. Delighted to be involved in spreading innovation at pace and scale and improving public services for the benefit of the public.
Great, thanks, Guy. John?
Great. Well, I guess just to echo some of the things Guy said. So I'm Jon Siddall, Chief Exec at the Southwest Academic Health Science Network, and as Guy said, we're one of the 15 that was set up back in 2013 by NHS England. And the way I often describe the work we do in the Southwest is really to spread innovative practice across a health and care system for all the reasons that Guy mentioned. So it's about improving population health and generating economic growth through that. The way we do that, I typically describe as the 3 main areas that we focus on, certainly for our work in the Southwest, and I think very similar to other AHSNs around the country. So the first of those is we help to support partners to spread innovative practice in practice. So we actually do that in our regions, taking things we know work to scale. We do a lot of work around then building capability in our region and across the AHSN network to help organisations to do that better. So that's skills in quality improvement, in culture, in networks to scale innovation. And then more recently, an area that's become, I think, particularly valuable during COVID is the work we do around supporting our partners across the region, but then nationally through the network to help evaluate and learn about change and about innovation. And I'll talk a bit more about that maybe later on, but something that's been, I think, particularly valuable during this period of real change.
Thanks, John. And I think throughout my career, I've always been interested in change management and sort of leadership in that context as well. So maybe that'll come into the chat we have as well. In terms of what drives us as individuals, I'm really interested to hear a little bit more from you on that. I mean, for me, doing the right thing is at the heart of what I'm about, I would say. For people, with people. It's one of the reasons I came into health and care after an early career in a different sector. And I think some of my interests link to what you've been saying as well, particularly around collaborating with others, because running a small organisation like Future Care Capital, we go about our work and we have impact and make impact mainly through collaborating with others and working with others. And some personal interests for me in the health space are particularly around longevity, the idea of the 100-year life, and the innovation context and how we can support people to live long, healthy lives through innovation. And I'm particularly interested in this whole concept of well-being across, physical health, emotional health, mental health, and place as well. But what really drives you, John? What are your key drivers?
Yeah, good question. So I think I'll probably talk about three things that drive me when I've been sort of asked this question in a few different ways before, which are really, really similar to some of the things you've talked about, Greg. So the first of those, I think, is probably purpose. So I think I am motivated by having a meaningful end goal to what I'm working on. And that's changed over the years. But that's largely why I pivoted my career in kind of my mid to late 20s from the commercial sector to purpose-led organizations and eventually healthcare, because although the intellectual challenge in the commercial sector is fascinating in terms of what I was trying to achieve, the end goal of that was not necessarily particularly personally motivating. So I think that kind of purpose of what I'm trying to achieve is at the heart of it. Then within that, the second thing I often think about is I think I'm really driven by problems. And I know that's kind of an obvious thing to say, but I genuinely am really fascinated by how do you really understand problems as the route to solving them. And I think it's the bit that often gets skipped in the world of innovation, is actually defining the thing we're trying to solve in the first place, rather than the solution itself. And I personally think that that's the route to really tackling some of the intractable stuff that we've really struggled with. And right now, I guess that problem that I'm particularly interested in my current role, since I joined the AHSN back in April, is how do we really create healthcare systems that will take innovation to scale? And I think that's the big challenge for the 21st century. If the 20th was about discovery, for me, that's the big challenge for the 21st. And then the final one, which I think is the route to kind of tackling both problems and having purpose, is people. And I guess that's at a very basic level, people are the answer to all problems, right? Because we won't solve anything with an individual person or an individual product or service. It's the combination of these things and people coming together to do that. And I think we often talk about, people talk about systems and organizations being the problem, but without people, there are no organizations and systems. Therefore, it's about how you get people to work together, to collaborate, to understand each other, how you influence them to do that, both as a leader of an organization, but probably, as you said, Greg, AHSNs really can't achieve anything at all without others that we work with. So how we get people working together towards common goals around that problem that I'm particularly interested in at the moment is I guess at the heart of it. So that's it for me. I guess purpose, problems, and people. Spot the X strategy consultant with the three bullet framework.
Yeah, I like the alliterative nature of that, for sure. I mean, in terms of the getting people to work together in the COVID-19 context, that's certainly brought about its own challenges, hasn't it? But I'm sure we'll come on to that. Thanks, Jon. Guy.
So, very similar for me. So I think I'll just acknowledge similar drivers about having sort of moved between private and public sector and public and private sector, very regularly over my career. That the sort of common thread has really been about public service and seeking to get out of bed for something worthwhile that makes the world a better place and help people sort of flourish in their daily lives. Like Jon, I see the need for system reform, and often feel like I'm searching out collaborations with like-minded people, because feels like we're sort of swimming against the tide, trying to change a system that's more than 7 years old, more than 70 years old, and bureaucracies are hard to shift, I suppose. But I really wanted to pick up on the working with and through people point that Jon started with. I think that's a big driver for me as well. I really enjoy collaborating across organizations and across sectors, and integrating people, helping form new collaborations, new teams, and bring their talents from sort of different sectors and organisations. And I like the sort of OD aspect and team development aspect that goes with that. So helping people work better together, because joint working, sharing knowledge, collegiate partnerships doesn't happen by itself. It's it's an interesting, stimulating and worthwhile challenge to rise to in itself.
Thanks, Guy. Thanks both of you on that. I think the theme clearly of working with and through people is central to all of us. And that brings me on to my next question, really, to open up, which is about the experience we've had of the last 6 months. And I guess, from where I've been sitting, we've had a lot of opportunity in my organisation. We moved very quickly to a virtual way of working in early March of 2020. And we've never been so busy in some respects. But of course, as time rolls on, and you're trying to work with others, both as a team yourself and with collaborators and partners externally, some things work well, some things don't work so well. And I guess I'm really keen to understand what's emerged for you as important in the context of what you've learned over the last 6 months in terms of your kind of personal mission and working with other people.
Is it your turn to go first, Guy?
I'll go with you, Guy.
Yeah, I sort of break the last 6 months down into two halves, really. I think the 8 weeks of March and April generated an enormous sense of common purpose across the health and care sector, and it felt very comfortable, and that's not the right word, very energizing to rise to the challenge and make a contribution and accelerate some stuff that seemed bang on relevant, and deprioritize other stuff to release resources to offer for something that was more timely and urgent and important. But more recently, I found it much more difficult to deliver value through work. I think we've just been in a few summer months of planning and planning with new entities that have had to norm, form and storm rapidly in order to become useful. So, recovery cells and restoration boards and that sort of thing. So for a non-statutory organisation, I think it's been quite hard to work out what table to sit around to have a seat at that table, despite, having worked in my patch for 10 years and knowing most of the leaders in the system. It's just been, a different map has been drawn. And I think only recently, perhaps with the Simon Stevens and Amanda Pritchard phase 3 letter of the 31st of July, has a greater sense of purpose and clarity of priorities been re-established. So, I'm pleased to be back in the upbeat, not floundering phase that I feel like I've come through in recent months.
That's good to hear. Excuse me. Thanks, Guy. John?
Yeah, I think it's similar. I think that sense of people taking a bit of a deep breath in kind of late June and July before we now start to kind of regroup and get ready for the next phase of the situation we're in it resonates with me as well. Well, I guess so. What would my reflections be? Well, maybe personally, first of all. So I started my role during lockdown as chief exec in mid-April. So it's probably, summary would be challenging and fascinating at the same time, would be the combination, in that it's been deeply challenging in terms of the pace and nature of the work, and having to do that virtually and build a relationship with partners and a team in that way. But you know, there are many positives that I've drawn from that as well, in terms of, I think, the pace we've been able to move at. So when you remove certainty of everything, suddenly making change becomes much more comfortable in the context of everything's changing. So I think there's been something interesting in that. And then I guess it's been fascinating for me because we've moved from a world where, you know, although it didn't necessarily feel it at the time, the world was pretty predictable up until March this year. And all of a sudden now it's really not. And that those kind of, I guess those capabilities of agility and resilience and being comfortable with change have become a necessity for every organisation, rather than necessarily those that just really embrace that and saw that as part of their DNA. So I think there's something interesting in how we've had to evolve as organisations. And Guy, you know, we've been talking about this across the network of AHSNs of how we've seen that play out. In terms, so that's, I guess, a personal reflection. In terms of the organisation I work for and the system that I operate in, you know, clearly it's been a hugely challenging period, and it's been, you know, a real privilege to be part of it, actually. And having worked, coming from an organisation, my previous work at Guy's and St Thomas's, where had the privilege of working very long term and looking at how we make changes over a kind of 10-year period. To be working on something that's got to be done in 2 weeks was really fascinating, and a real challenge and a pace change, I guess, in some ways. And it's been brilliant working with, you know, seeing the quality of people we have in the health and care system and what they can get done when you give them the opportunity to do it. I think it's been really inspiring to see, and I'm very grateful to be part of that, both in the region and across the AHSN network, in terms of what we've achieved. Maybe then the final point I mentioned, and I'm happy to build out on this a little bit, is coming back to that point I made at the very beginning of our conversation around what we've learned from this period. And many of the AHSNs, most of the AHSNs across the network, have been looking at supporting our systems to capture that learning while it's fresh, and think about what that means for the future. And the partnership we've had with Health Foundation and NHS Confed around Reset is kind of starting to translate some of that to others as well. But one of the things I've been really struck by that is the conditions that we've interpreted that have enabled rapid change, that I think we're now trying to work out, how do we hold on to some of these things in order to help us with the future as well. And you know, many of the AHSNs have been writing about this. My colleague Sarah Robins in our team has talked about it through our work in Somerset and Devon and Cornwall, kind of getting underneath the surface and understanding what has enabled this rapid change to take place, as well as the things that have, and the things that really stuck out for me in that work, and she wrote a blog on this a couple of weeks ago, is so the point Guy made about shared purpose and focus. So never before have we removed conflicting priorities in the way that we just have in the last 3 or 4 months, whereby we said nothing else matters more than this. Whereas often in a health and care system, of course, everything matters and everything is important, and therefore how do you prioritize is a real challenge. So I think there's been something really inspiring about seeing people rally around a clear goal, and the progress you can make when you do that. The second thing I've really observed is, in order to make that work, we've been pushed to create more psychologically safe environments for people to operate in. So in the way that people have been permissioned to try things out, work with others, work across organisations, across systems, because they're really clear on what the end goal is. And because the pace was so rapid that we had to enable people to do that. And some of the work we've seen, you know, accelerating stuff we have planned, like community level treatment assessment units in Cornwall, which have been on the cards for a few years, and then we've done them in weeks, whereas it's taken months or years in the past. And then the final thing around that is just how valuable cross-organizational systems have been in making that happen. So things like shared data, shared platforms. We've particularly seen this around some of our intermediate care management, and how, you know, the use of shared data and shared platforms has enables all of those changes to take place as well. So yeah, lots more I could say about that, but I think there is something really interesting about how we draw on to not just what has changed, but how it changed, and the underlying conditions for it.
Yeah, agreed. Thanks, and some real insight there. It's brought to mind that, and sorry, I can hear myself talking as I talk, so I hope that's not reverberating your end. But when I think about the phases that we've been through in my organisation, and the work that we've done over the last 6 months and where we're headed now, so much of the focus, I think, as you've kind of been describing, is linked back to leadership and resilience and common purpose. And it reminds me of another hat I hold or wear, which is with Exeter University, the Exeter Leadership Partners Programme, where we're working with leaders who are on boards and helping to develop people across different sectors who are facing, the challenges that we're all facing during this period of time, whether we work in health and care or not. And some of those conversations have just come back to the way that the acceleration of collaboration across sectors has helped some of them cope with and deal with situations, even though they never really had any sense or involvement in health and care, and how that's helped them understand as well that the world of health and care, certainly in the future, is being seen through a different lens by people, which is not through the pure sort of bricks and mortar NHS buildings and care homes, which play such a central role in the delivery of care, but actually communities and the built environment and employers. And as we come out of lockdown and try to get back to some sort of normality, what that means. So for me, some of the learning has been around the critical role of the statutory sector, but also how other organisations and communities of people have rallied around the opportunity to support one another in communities. Because at Future Care Capital, we know that the NHS is such an iconic institution, and we recognise that, and I've worked in it for a long time in the past. But social care, certainly during COVID-19, has been, shown and seen to be an area where, we don't have the same ability or agility, particularly around sort of data and the way that the government and other bodies have been able to harness that data quickly in the way that we have been doing for such a long time in the NHS during crises like the pandemic. So what I suppose we used to, or still call the VUCA world, seems to be VUCA 2 to me, the volatility and uncertainty of the world we're leading in, and particularly the complexity of health and care seems to be changing even more and becoming even more intense in my view. So in that context, if we think about the sort of historical approach to delivering health and care through that bricks and mortar model, as I described, and maybe how we can focus a little bit more on mental health and well-being alongside that. That debate has been going on for a long time. But in what ways do you think that population health and well-being could be better redistributed in ways that would serve more of a sort of move towards well-being and mental health alongside other areas of health?
Gosh, there's so much I want to say. Let's hope it comes out coherently. I wanted to pick up on some of the things that both of you have just said to sort of try and build a bridge into this bit of the conversation. So, like John, I've valued being in an organisation that's got a remit and some capability around capturing learning and evaluating what was going on in March and April and why the successes happened and why some of the less good stuff happened. I want to pick up on that theme of empowerment that you've sort of touched on with volunteers and communities responding. From our interviews with sort of system leaders, how the large-scale change happened in that first phase of the COVID response had a lot to do with decision-taking changing and not requiring meetings to be planned at a time when everyone was available to contribute to the discussion. So, faster decision-taking mechanisms and faster access for frontline staff to decision makers and their ability to just pick up the phone or get hold of somebody to secure some supplies of something or to get some permissions to do something. So I think that theme of empowerment within the statutory sector is something that all AHSNs have heard in their learning exercises and after actions reviews. And I think that's demonstrated in across the whole system too, not just the NHS. So I'm really struck by my, sort of good neighbour activities of being part of a COVID-19 mutual aid WhatsApp group. Yeah. And how much faster that got off the ground compared to the local resilience forum organised by the local authority, or the NHS volunteering Good Sam scheme. And I think as well as this sort of huge surge of goodwill and common purpose from health and care staff, there's been this huge upsurge of goodwill and volunteering and common purpose from, neighbours and communities too. So I think that sort of holistic response to whole people's lives has helped to compensate for an NHS that, as you've said, prioritises physical health ahead of mental health, and NHS care ahead of social care in terms of funding allocations and government priorities and whatever. And to see people just responding to, this greater health and well-being challenge in the community at a time when charities have been furloughing staff left, right and centre, and just when you needed them most haven't been able to respond as fully as they would like to, I think is a really impressive ingredient from UK citizens to respond to a UK crisis and a global crisis, of course.
It sounds like you think we've reached or even gone beyond a tipping point positively, where community action is a thing that we all recognise as a part of this for the future.
I'd like to think so. I really don't know what the future holds, and I don't know whether this sort of community action will sustain at the levels it is doing. I don't know whether the use of digital technologies or remote consultations will sustain in the NHS, but I get out of bed these days to help make that happen. That's for sure.
Thanks, Guy. Jon, what are your thoughts on this?
Yeah, I'd say I agree with a lot of what Guy said. So I'll maybe take a slightly different angle to the question around, I guess, how do we redistribute or rethink the way we use resources on population health? And for me, what's happened in COVID-19 is a really dramatic reminder of the underlying health inequalities in modern society. And Health Foundation's report last week around, I think they said, if you live in a disadvantaged area, you're nearly 2.5 times more likely to die from COVID than you are in a more advantaged area. And that for me is not new. Like we know that about many different diseases, about many different population health challenges, is that they play out unequally in populations. And I've been very fortunate in my career for the last few years before I joined the Academic Health Science Networks again, to be working at the heart of that inequality in inner city environments with my working guys. And so for me, I think the redistribution and the challenge is less about how do we sort of move money around a system and move resources around a system, but more around how do we better understand the specific needs of populations and respond to them in a more precise and specific way. So we see that play out in issues like mental health, like obesity, like multiple long-term conditions. They're all issues that play out unequally in populations, and COVID has been exactly the same. And we see that through our work that we do at primary care practice level, looking at the nature of populations within those environments as well. So what in practice, I think, to do something I guess material about that, there's a few things that I often talk about I think we need to do better. So the first is we need to be much more precise about the way we approach population health. So we tend to approach it from a whole population perspective, and I think we do need to do that, but we need to be much more targeted as well. And what we've learned through a lot of our work in primary care is targeted interventions for those most disadvantaged by particular health conditions is different in different places. So it's a very granular exercise. It requires deep knowledge of place in order to be able to do that. We also then talk about the need then to then personalise care delivery and support for people in order to respond to that precise and an individual group need as well. So, you know, the simple way we always talk about that in personalised care is how do we move towards what matters to you rather than what's the matter with you. And then finally, I think to Guy's point, we have to make all of this digitally enabled. And I think that links really well with both of the former 2 points that I've made around being more precise and more person-centred, in that if you go to any digital or tech organisation, they start with the user, and then they build and iterate and develop based on the user needs. And I think we've learned a lot in COVID about how we do that better, and I think we could go much further on that as well. So that for me, in summary, I think the route to tackling some of the big population health challenges we have is around inequality. The way to tackle inequality to achieve a population health advantage is through much more precise interventions, personalised to individual people, individual groups.
Yeah, thanks, John.
Could I
Sorry,
just
Guy,
add-
you want to explain?
Yeah, I wanted to add to that, Greg, and sort of pick up on your bricks and mortar point again, because I think there's something about changing the system here, and changing measures of success, really, and measuring value added through public services and, you know, the spend of taxpayers' money, rather than just balancing the books and not overspending. And I think because the system doesn't measure value added in terms of, you know, population health, then prevention, early intervention, mental health, supporting, you know, hospices and voluntary sector and social care doesn't get as much investment as I would like to see it get, thinking that with more investment in those areas, more value would be added in terms of, you know, population health and well-being gained.
I agree. Actually, it reminds me that my work as a trustee of hospice care in Exeter in Devon, some of the challenges we've had in the whole hospice sector, actually, which does fantastic work, plays very well into that point that you made there about the system and value add. Flying the flag for hospices.
I've just started this week as a trustee of the Sue Ryder.
Fantastic. Congratulations. Well, I'm sure you'll love it, because I love my work with hospice care for sure. And just thinking about the points that you both made there reminds me of two things. One is some work we did at Future Care Capital a while back called Data That Cares, which was really looking at one of the key points was the need to understand the granularity of data that reflects the subtle sort of local nuance of context and place and the situation in a care context that is often lost with a maybe one-size-fits-all planning from a central model nationally. So that's one thing that came to mind. And the other point was about John's reference to sort of understanding the needs of populations better. Some work we've been doing, which I think I've been discussing with both of you, is developing a concept called care labs, where we've been thinking through with others how there's this sort of disconnect in a way between the expectations that the public have of what they're maybe entitled to in terms of care and healthcare, and what the government can realistically provide through the system now and in the future. And therefore, in the context of what we've been learning in recent months around place and communities and, you know, all of that, bringing that together, how you bring together people, organisations, and those who know what's going on in a community to almost sort of re-envisage the future of health and care and what it might look like, with the different moving parts, some of which are bricks and mortar, as I said, and some of which are other elements we might not have thought of before. An example might be the role that financial services play in the future of health and care. Well, what does that mean? Well, if you think of the 100-year life and this concept of how we're now living a totally different life to those of perhaps of our grandparents, education, work, retirement, it is going to be different. It already is. People are having multiple careers. You can't expect to just retire at, say, 60 or even before that. And people will want to work later in their life. So how do communities embrace that? How do we embrace that and use that as part of continued health and well-being, both physical and mental health? So these are things we're exploring. We've got one of those due to run in Plymouth in the next couple of months, and also another one in Middlesbrough, which we're working on. We're coming towards the end, really, of our chat. It goes so quickly. But I wanted to just hone in on your specific work around innovation and scaling innovation, because this is a real interest to us at Future Care Capital. And just maybe say a few words about, in the context of the current challenges, workforce challenges and everything else we've described, how can health and care innovation take on the burden of care, if you like, in terms of the value add that it brings?
Jump in first, Guy.
Thanks. I just want to remind everyone of the demographics of the UK and the Western world. So we've got a growing and aging population, and I remember from the ONS forecast that we're sort of halfway through a 20-year period ending in 2030, where there will be 33% more people aged 65 and over in 2030 compared to 2010, and only 3% more what used to be called working age folk aged 18 to 65. And with the burden of illness being correlated with older age, not only is there going to be 33% greater increase in illness in the population, but it's going to be bigger than that. So if technology doesn't take more of the burden of care, it's just hard to see where the pairs of hands are going to come from to provide health and social care in the way we know it now. So that's really why Jon, myself, the AHSN network exists to help the science and the tech and the latest research get to citizens, communities, patients a bit faster than it otherwise would do.
Thanks, Guy. Agreed. Jon?
Yeah. No, I completely agree with Guy. Helpful reminder on the scale of the challenge as well. But so the only maybe a couple of things I'd add is, firstly, going back to what I said very early on in our conversation, that innovation isn't just about discovering new things, and actually innovation is really about putting things into practice so they have value and impact. And that's why I'm almost as interested in stuff we've known that we need to do for 10 years but haven't been able to do as I am with the shiny new things that we're trying to get to market and into the health and care system as well. So not losing focus on the real opportunities for scale of impact through things we know that work, alongside the translation of new things into practice, and the balance of both those two things. And for me in the Southwest, I'm particularly interested in that challenge of scale and how do we take things to scale, and certainly what we've been doing across the AHSN network as well. And then I guess the other thing I'd finish with is going back to that point on really making sure we're tailoring innovation and technology to the population which we're trying to support or respond to. And I think technology enables us to be much more personalised in the way in which we respond to people's needs and the support they require, through both how we understand data to inform that, but then in the response and the solution to it as well. And I think the biggest risk is that we fail to realise, well, not the biggest risk, one of the biggest risks is that we fail to realise the potential of using technology to better personalise care, as well as deal with the scale and the burden of care that's coming with an ageing population as well.
Thanks, Jon. Great points. And I just written down a few notes there because I think this comes together neatly for me. When we started the conversation, we were talking about people, weren't we, with your 3 Ps, Jon, and that idea of trying to understand people, particularly through change and the leadership challenges of that as well. But we seem to have ended on a technology note, and in the context of challenges around algorithms in recent months, and the way that people see technology, both in terms of its potential and maybe their fear of technology. I think if we're going to understand the potential of technology and then use that at scale for impact, then you almost have to sort of bring together the people and tech piece, don't you? And you said, harness the potential of tech for better personalised care. And I think that's, for me, a really good place for us to end this particular conversation, linking those two. And that's kind of what I'd hoped to get to in this chat as well. Because for me, that's what all of this is about in terms of the work we do. It's about people, it's about the future, it's about technology, and it's about care. So thank you both ever so much for joining me today. It's been a great conversation. I've really enjoyed it, and I hope you have too. This is part of a series of future care chats that I'm running with leaders and others, as I say, across the health and care sector and beyond. But for today, I'll say thanks and goodbye.
Great. Thanks, Greg.
Thanks.